All right, let's get right into it. Welcome, focused learners, to this high-yield explainer. Today, we're setting the stage for a rapid-fire, totally comprehensive board review of Hansen's disease, or, as you probably know it, leprosy. So if you're gearing up for your medical entrance exams, you are in exactly the right place. Let's do this.
Okay, quick trivia question to wake everybody up, and test makers absolutely love this one, by the way. What obligate intracellular bacillus loves armadillos, grows at exactly 27 degrees, and simply cannot be cultured in artificial media? Well, you guessed it, it's Mycobacterium leprae. This bug has a super slow doubling time. We're talking 12 to 14 days. And fun fact, it relies on 9-banded armadillos as a zoonotic reservoir, particularly down in the southern United States. Oh, and it strictly infects macrophages and Schwann cells.
Here's our roadmap for today's explainer. We're going to tackle basics and cardinal signs, the Ridley-Jopling spectrum, WHO simplified classification, distinguishing leprosy reactions, and we'll wrap it up with MDT and crucial side effects.
Section 1, Basics and Cardinal Signs. Let's jump in.
Now this is actually pretty fascinating. 27 to 30 degrees Celsius is the optimal growth temperature for M. leprae. Because this is just a bit cooler than our normal core body temperature, the bacteria have a really strict preference for the cooler parts of the human body. So you're going to see it specifically targeting the skin, the peripheral nerves, the testes, and the upper airways. Definitely keep that in your back pocket when you're reading through a patient vignette.
Okay, so what's the absolute gold standard for diagnosis? It's what we call the rule of 3 for cardinal signs. First, a hypopigmented or erythematous skin lesion that has a definite loss of sensation. Second, a thickened peripheral nerve with sensory impairment. And third, a positive acid-fast bacillus finding on a slit skin smear, biopsy, or PCR. But listen closely to this part. You do not need all 3. Finding just one of these cardinal signs is completely sufficient to lock in the diagnosis.
Section 2, the Ridley-Jopling spectrum.
To really grasp this spectrum, we've got to talk about cell-mediated immunity, or CMI. Think of Hansen's disease like a massive immunological tug-of-war between the host CMI and the bacteria. The strength of your patient's CMI basically dictates exactly where they're going to fall on the disease spectrum, stretching all the way from tuberculoid on one side to lepromatous on the other.
Board examiners absolutely love testing this exact comparison. Let's break it down. On the tuberculoid end, or TT, the patient mounts a really strong Th1 cell-mediated immune response. Because the immune system is putting up a great fight, you'll only see a few, really well-defined, dry, anesthetic lesions, literally just 1 to 3 of them. And naturally, their Leperman test, which measures that CMI, is strongly positive. But on the exact opposite end, we have lepromatous, or LL. Here, CMI is poor, or honestly completely absent, so the bacteria just multiply unchecked. This leads to innumerable, bilateral, symmetrical lesions, and because the CMI isn't showing up to the fight, the Leperman test is going to be completely negative.
Hold up, major red flag here. This is a classic exam trap, the lepromatous paradox. We just established that tuberculoid lesions are dry and highly anesthetic, right? Well, in lepromatous leprosy, fresh LL lesions actually start out with no sensation loss. I know, it's totally counterintuitive, which is exactly why test makers love it. Do not let a fresh, shiny, symmetrical lesion with perfectly intact sensation trick you into ruling out LL.
Next up, Section 3, WHO's simplified classification.
So all that immunology is great, but the World Health Organization essentially turned this into a strict numbers game for everyday practical treatment. You're either paucibacillary or multibacillary. Paucibacillary, or PB, means exactly 1 to 5 skin lesions, 0 to 1 nerve involved, and a totally negative slit skin smear. A good trick is to think P for a petite amount of bacteria. On the flip side, multibacillary, or MB, means 6 or more skin lesions, more than 1 nerve involved, and a positive slit skin smear. You absolutely need to know these exact cutoffs for your exams.
Moving right along to Section 4, Distinguishing Leprosy Reactions.
Okay, before we even look at the clinical symptoms, let's look under the hood at the pathophysiology for both types of reactions. A type 1 reaction, or T1R, is a delayed type 4 hypersensitivity. It is an abrupt, sudden upgrading of the cell-mediated immunity. Now, a type 2 reaction, also known as erythema nodosum leprosum, or ENL, is a completely different beast. It's an immune complex type 3 hypersensitivity, which is essentially an Arthus phenomenon involving antigen-antibody complexes and complement.
The crucial point here, cementing this clinical contrast in your brain.
In a type 1 reaction, which mostly hits those borderline types, the patient's existing lesions suddenly swell up and turn red. You also get this very prominent, sometimes silent neuritis that can actually cause acute nerve paralysis. Now, contrast that with a type 2 reaction, which hits the Leprosy types. In T2R, the patient develops brand new crops of painful, tender nodules, usually on the outer limbs and face. And it comes with systemic stuff, fever, malaise, and multi-organ involvement like orchitis or nephritis. So remember, existing swelling versus brand new nodules. That's your key differentiator.
Because the underlying mechanisms are so different, the pharmacological management is vastly different too. For a type 1 reaction, you're going to treat with high-dose prednisolone, usually 40 to 60 milligrams, and then taper it off super slowly over about 20 weeks. But for a type 2 reaction, thalidomide is actually the most effective treatment here, alongside prednisolone. You'll also use clofazimine at a higher dose for a month just to prevent that ENL from coming back.
In our final section, number 5, MDT and crucial side effects.
The multi-drug therapy regimens are actually distributed globally as straightforward WHO blister packs, and they're based entirely on those PB and MB classifications we discussed a minute ago. Step 1. Paucibacillary requires a combo of rifampin monthly and dapsone daily for exactly 6 months. Step 2. Multibacillary requires a heavier, longer regimen. You still use rifampin and dapsone, but you add clofazimine and you have to treat for a full 12 months.
Hold up. Huge exam warning here. The toxicities of these specific drugs are virtually guaranteed to show up as test questions. You literally have to know these to pass.
Let's rapidly review these because they are visually striking and sometimes fatal. Rifampin is going to turn your patient's urine and bodily fluids orange-red. It's totally harmless, but you absolutely have to counsel them on it so they don't panic. Dapsone is incredibly high yield. It can cause hemolysis, so always check for G6PD deficiency. It can also trigger dapsone hypersensitivity syndrome, which is a potentially fatal mix of fever, rash, eosinophilia, and hepatitis that usually kicks in about 6 weeks into treatment. Clofazimine causes this psychologically distressing brick red or purple skin discoloration that can last for months or even years. Actually, it's the main reason patients end up refusing treatment. And finally, thalidomide, which, remember, we use for type 2 reactions, is a severe teratogen. It is absolutely 100% contraindicated in pregnancy. No exceptions.
So, to wrap up today's explainer, I want to leave you with something to think about. We know M. lepra can actually survive out in the environment for 9 days, and its main route of transmission is through asymptomatic droplets from untreated multibacillary patients. Recently, the WHO recommended a single-dose rifampin post-exposure prophylaxis for household contacts, which drops the risk by around 60%. Given its long environmental viability and really stealthy transmission, how might this targeted single-dose prophylaxis finally reshape the global eradication of such an ancient disease? It's pretty incredible to think about. Thanks so much for hanging out and learning with me today, and seriously, best of luck on your exams. You're going to crush it.